Good afternoon, everybody. We're going to get started on the second half of our program, and I hope everybody got some lunch. If you haven't, please go to the back of the room and grab lunch. And, pardon? Oh, we have a phone left in the back of the room. Whoever's phone this is, I know you need it, want it.
It's where branch. I got it.
Okay,
Yeah.
it's where branches. Okay, Dr. Branch. All right. I'm Kathleen Digree. I've been the director of the Center of Excellence in Women's Health for over 20 years, and we have been doing women's health conferences for almost 10 years here at the University of Utah. And this is really a special one for me because Alfred Chung contacted me in the fall and said, we really want to look at sex as a biological variable. How could we do that? I said, well, why don't you join us? So this morning we had, if you didn't join, please listen to our recording. We're going to have a recording online in the Center of Excellence website where you can listen to some amazing lectures that stimulated all kinds of research this morning. Well, this kind of program does not happen without a lot of work. And I just want to tell everybody about the committee of the Center of Excellence in Women's Health. We had an amazing program committee. Michael Varner, Camille Marino, Vidya Gopinath, Idaho Gomez, and I'm going to murder this last name, Lubreras, Katie Ward, Cato Farrell, Lisa Taylor Swanson, Deanna Kepka, Karen Frost, Lisa Gren, Nikki Mihalopoulos, and Alesko Clifton from Internal Medicine. And the brains behind everything we do is Leanne Johnston, and I want to give her she organizes the food, she organizes the venue, she organizes me and all of us, and we are so grateful. And I also want to say thanks to Nicole Frank from Basic Science and Physiology, Renal Physiology, for all her help as well. And with that, I would like to turn this over to Camille Marino to also introduce to you the Center of Excellence and all the things we have going on here.
Thanks, Dr. Degree. We wouldn't actually have a Center of Excellence without our fearless leader, Dr. Kathleen Degree. So thank you for your leadership. And the Center of Excellence, for those of you who do not know about the history of it, was founded by Drs. Kathleen Degree and Michael Varner back in 2005. And it's continued its mission to improve the health and lives of women here in Utah, to connect individuals across many disciplines at University of Utah campus and beyond. When I joined the COE, so Center of Excellence for short, or COE for short, back in August of 2022, our multidisciplinary team has continued to grow, providing excellent healthcare and education for women, not just across the lifespan, but also the health span, honoring different cultural practices and beliefs. In addition, as a COE, we stay committed increasing the education for women, researchers, healthcare professionals, and medical providers on many women's health topics. So I can't just say that without giving and sharing examples. So just a few examples of these endeavors that have started and or continued this past year include our annual COE symposium that you are all in attendance today and has come into fruition over the years because the efforts of a multidisciplinary planning team that Dr. Degree just mentioned, and also the organization of Leanne Johnston working behind the scenes. We also started Project ECHO for midlife women's health education, and this is a virtual platform that supports a collaborative, evidence-based healthcare for midlife women. And that is held every Wednesday, first Wednesday of each month on Zoom. So if you have any questions about that, feel free to come talk to me. We also have CRAM. CRAM stands for Clinical Research and Methods, and it continues to host monthly lunch seminars highlighting research opportunities, resources, and updates. We have the Scope Radio, highlighting the 7 domains of health, led by Drs. Kirtley Parker-Jones and Katie Ward. And the Scope Radio has a repository of many podcast episodes, incorporating a holistic concept of health. And last but not least, we have the Utah Women's Health Review, which is a peer-reviewed online journal led by Dr. Karen Schleep and her associate editors, some of whom are in this room today. Furthermore, our COE is an active participant of a statewide initiative called the Boulder Way Forward, which also some of you may be familiar with, and which is also led by Dr. Susan Madsen at Utah State University. So as you can see, the COE truly has stayed busy serving the health needs of women in our state since its inception in 2005. We are proud of the achievements of our members and the continued collaborative relationships we've formed over the decades. We would like to welcome you today to our annual symposium focusing on innovations in women's health, and we are so happy you are here and enjoy our outstanding lineup of speakers and talks. Welcome, everyone.
So our first we're not shying away from hot topics. There may be language in places that don't allow hot topics, but we don't shy away from it, and you're going to hear hot topics today. And the hot topic we're going to start with is obesity. And we're going to talk about the changing landscape. And with us, we have amazing faculty here at the University of Utah that are going to try to help us tackle the problem. And I'm going to present a patient. And I'm going to introduce our speakers kind of all one. And then we're going to get together and kind of talk about the case that I'm going to present. Our first speaker will be Dr. Juliana Simonetti. She is the director of Obesity Medicine Program and the co-director of the Comprehensive Weight Management Program here at the University of Utah. And her special interest is in women's health and serving underserved populations. She's originally from Brazil and is fluent in Portuguese and Spanish, and she's just a delightful human being as well. Tanya Halliday is an assistant professor in the Department of Health and Kinesiology. She's an adjunct professor in the Department of Nutrition and Integrative Physiology, and she's really focused on lifestyle interventions, appetite regulations, and she's a principal investigator on numerous grants, including NIH grants. Then we have Dr. Hannah Reiber, who completed her Doctor of Pharmacy at Drake University in Des Moines, Iowa. And then she did a residency in ambulatory care pharmacy and has been in family medicine program at St. Joseph Regional Center in Indiana. But then she joined us and she's an associate clinical professor in pharmacotherapy here at the University of Utah and is at Madsen Family Health. And last but certainly not least is Dr. Ware Branch, who is a professor of obstetrics and gynecology here at the University of Utah. He does maternal fetal medicine, and he cares for patients who are high-risk OB. He has a special interest in autoimmune disease, which we did hear a lot about this morning. And he also is the go-to person for taking care of overweight and obese women of reproductive age. So we have this stellar panel to tackle a clinical problem, and that is this woman here. So Sharon is a 34-year-old woman. She is sent to me because I'm a neuro-ophthalmologist and a headache provider and in the Department of Ophthalmology at the Moran Eye Center, which I want to thank the Moran Eye Center and Ethan Peterson for helping us with today's program. But she's obese. She's got a BMI of 35. She's had recent weight gain. Otherwise, she's been rather healthy, and I diagnosed her with idiopathic intracranial hypertension, this condition of disc swelling and very bad headaches. And it's seen in women of childbearing age. 90% of the women who have this are obese or overweight, they all have severe headaches, and threat of visual loss looms over them daily. And the treatment is actually weight loss, and we also use a diuretic to limit spinal fluid production. My patient is a symptom of a problem we have in the United States, and these graphs are from the CDC. And first, just start looking at the dark red portions of the United States as they go redder and redder. And then they had to change the color code in 23 because they were so red that they needed to change the code now to even worse BMIs. And then that's where we are. And health consequences of obesity are many, including diabetes, as we heard about this morning, cardiovascular disease, hypertension, dyslipidemia, metabolic syndrome, all of which we heard about this morning, polycystic ovarian syndrome, sleep apnea, arthritis, certain cancers, depression, pregnancy loss, and increased mortality. So we are going to be in this panel discussion, and each speaker will come up and give us a little introduction to their area. And then we're going to be trying to tackle new thinking about how we measure obesity and how we think about diet and exercise for our patients. And then what are the new thinking about medications, which if you haven't been listening to the news, you're missing out on all these obesity drugs that are coming out here. And then how do we approach women of childbearing age and pregnancy? And can we use these new medications on them too? So with that, I'm going to ask each speaker to come up. I'm going to put the speakers up here again. And Dr. Simonetti, I'll start out with you. And then you have slides, right?
I do. It should be loaded, right?
Okay. Let's see. Where is... Oh, you got it? Okay.
Oh, someone is loading the... Well, it's great to be here in the presence of so many amazing providers, so many amazing physicians and individuals that are caring for our patient population. Whoever thought when I started this path into obesity medicine that I would have, right, it would be like the hottest topic that we have. I remember having maybe 5 medications to treat my patients. And when I did my fellowship, when I started doing my fellowship, it's all right here. So when I got interested in obesity medicine because I was working at a community health center doing internal medicine, and many of the patients I was seeing, there were females that had many of metabolic issues associated with obesity, and he felt that we were often band-aiding the problem by treating their hypertension, by treating their diabetes, but really had no tools in helping them treat the root cause of the problem, which was their obesity. And I always remember my preceptor at the time, and I was like, why can't we give them a med? And she'd be like, well, I don't feel comfortable. I didn't have training in it. So I ended up getting additional training, and there were 3 fellowships at the time. And I always remember I told a colleague who was a nephrologist, and I said, oh, I'm doing this fellowship in obesity medicine, and he started laughing hysterically. He's like, what is that? And who knew that this is like the hottest topic now, and we have all these amazing drugs. So right now, I'll just give you a really brief overview of obesity and the pathophysiology and how we're thinking of medications, and we can go into more detail with our other speakers. So it is important to remember that not all obesity is the same, right? That obesity is this very complex disease with multifactorial presentations, and we have different phenotypes, clinical presentations, and treatment responses. So when we have had evidence of obesity for thousands of years within the human population, and we know obesity is a highly heritable disease, some studies, some twin studies suggesting the heritability of obesity being anywhere between 70 to 80%. So why are we seeing this significant increase in the rates, as Dr. Degree showed us in the maps over the last few decades? And we certainly can blame our environment, our obesogenic environment, where we have access to food 24/7. We have very high caloric dense foods. We have decrease in physical activity. Oftentimes, as physicians or as medical providers, we are prescribing medications that lead to abnormal weight gain. And then we have chronic stress, lack of sleep, and the combinations of all of this with our genetics leads to this significant increase in the epidemic of obesity. So, and as we think of the adipose tissue, we should be thinking as we think of other organs that can become diseased and dysfunctional. And the way that this happens is that we have overnutrition, and then we have increased demand of lipid storage, and we have the adipocytes that become hypoplastic and hypertrophic, they enlarge, and then we have hypoxia, the cell apoptosis and releases of cytokines, and then recruitment of leukocytes and causing this chronic inflammation, not only localized within the fat tissue, but also systemic inflammation. And there are studies that have shown this direct correlation with increasing BMI and increase in inflammatory markers. And this localized and systemic inflammation is truly what causes many of the metabolic issues that we see with obesity, right? So we have increase in adiposity, and then we have this release of adipokines, and then leads to impaired insulin signaling and insulin resistance, and leading to type 2 diabetes, prediabetes, and type 2 diabetes. Then we have increasing lipid production, lipotoxicity, dyslipidemia, that also contributes to fatty liver disease, coronary artery disease, stroke, CKD. And then we have the mechanical forces of the increase in the fat tissue that leads to renal compression, pharyngeal soft tissue compression leading to obstructive sleep apnea, osteoarthritis, GERD, and the list goes on. And I think it's really important to think of inflammation too as we're talking about the new drugs and how they're really addressing so many other conditions that are associated with obesity. So thinking of appetite control in the appetite and hunger is very tightly controlled, as well as our weight. Some might suggest that our weight is as tightly controlled as our temperature. We can really, bring it down by a certain amount, but then we have forces that pushes us back up. And what I want to just demonstrate here is that the appetite control centers of the brain, appetite control centers are all in the brain within the hypothalamus. So we have tissue hypertrophy from the adipose tissue that then releases leptin. The leptin then crosses the blood-brain barrier and binds to leptin receptors within the different neurons. Some lead to appetite suppression, and others induce satiety. Therefore, we have decreased hunger. We have decreasing food intake, right? We have excess nutrition. Then we have increasing energy expenditure, and that can lead us to maintaining our weight. So what happens, and what we have been studying and figuring it out, is that when you have mutations along this pathway, and we started doing genetic testing about 5+ years ago, and we started by knowing that maybe we're around 30 genes along this pathway. It's called the MC4R pathway that can lead to abnormal weight gain because your body, right, just not communicating properly. Your body physiologically thinks is really hungry, doesn't sense that you have enough energy stores, and therefore causes increasing hunger, decreasing satiety, decreasing energy expenditure, and severe amounts of weight gain. And we know the solution for these problems are, right? We know weight loss is a solution for the problem, that even 5 to 10% of weight loss can lead to significant improvements in health. So why is it so hard to lose weight? They have done the Look Ahead trial that looked over 10 years of patients that had diet and exercise and done lifestyle modifications, and they found that 85% of those that diet and exercise regained their weight within a year of losing it. And we know females in particular, as we age and there's hormonal changes, we have decrease in lean muscle mass, we have changes in fat redistribution, leading to abnormal weight gain and making it really hard to lose the weight. So part of it is because we have this metabolic adaptation. As humans, we have evolved to protect against energy deprivation, so we would survive in times of famine and war. So our body likes to be in a steady state, and this idea of having a set point, and our set point seems to often go higher. And as we start to lose weight, we have decreasing leptin, therefore we have decreasing satiety. We also have increasing appetite. We have increasing ghrelin and GIP. And then we have decreasing energy expenditure. We have increasing cortisol. We have decreasing fat oxidation, decreasing thyroid hormones. And that's when we hear, well, I lose about 5 to 10 pounds and I feel that my body plateaus and I regain that weight. And each time I lose and regain, I actually gain more, right? Because then I lose some muscle mass, my resting metabolic rate goes down. I regain the weight, I don't regain as much muscle mass. So each time I lose and regain, my resting metabolic rate is at a lower point and I tend to gain more weight. So how can we help our patients? This is really important, right? Thinking of obesity as we think of other diseases, as we think of type 2 diabetes, as we think of hypertension, cardiovascular disease, the basis of all that we do, it is focusing on lifestyle interventions with dietary modifications, physical activity, behavior health. However, it's important that we address the physiological reasons for the weight gain, and that's where the medications come into place. So the medications, and I'll go over some of the lists with you, medications and surgery. We're moving away to having BMI. There's new guidelines that are going to come out in October of this year from the Endocrine Society, really focusing more on not the number, but the impact of the adipose tissue within the body. So really adipose-based chronic diseases as class 1, class 2, and class 3. And those are some of the anti-obesity medications that we currently have. And this is the indications for usage of the treatment. BMI greater than 27 with a comorbid condition, or BMI is greater than 30. And we know that the medications, what they do is that they decrease energy intake, and they all work within the hypothalamus. They really work in the brain. And I know there has been questions before, even with the GLP-1s, does it really work by, decreasing satiety, or is it because it makes us feel fuller? Like, is it a mechanical reason, or is the physiological and central nervous system reason? And they tend to work in the central nervous systems and the appetite control parts of the brain. And thinking of the history of anti-obesity medications is that we have phentermine since 1959, right? That came in the market, and then we had orlistat. And I joke around and I say I only prescribe orlistat for patients that I don't like because it causes terrible flatulence and diarrhea. So I don't use it. And then in 2012, we had the phentermine topiramate as Qsemia, and that showed patients were losing around 10% of their weight. And then we had, shortly after, we had the approval of Contrave, which is naltrexone and bupropion. And this idea of having combined medications that work in different parts of the appetite centers of the brain that lead to be much more effective. And then we had our first GLP-1 approved for the treatment of obesity, which was liraglutide, known as Saxenda, higher dose than what we were giving for diabetes for weight loss. And we were thrilled with that because we were seeing more like 10%, sometimes 12% weight loss with some of those medications. Then we had setmelanotide, which is a newer drug that targets genetic mutations within the brain, the MC4R pathway. So it was the first treatment for genetics of obesity. And then we have the newer drugs with semaglutide, and that's where we got really excited about obesity treatment, semaglutide and tirzepatide. And the reason for our excitement is the amount of weight loss that we're seeing with these medications. The golden standard was around 5%, where many of the earlier drugs were approved by the FDA if they had 5% weight loss efficacy. And then as we were going on, tirzepatide, we're seeing up to 22.5% of weight loss. Now we're entering this new era of incretin and personalized treatment approaches for obesity, for the treatment of obesity. And I know we're going to go into more detail on this, but I just want to mention how the GLP-1 and GIP work. As we have food, it enters our our gut and our intestines, in particular carbohydrates and lipids, and leads to the release of GLP-1 and GIP, and that leads to increased satiety, decreasing appetite. And one thing I'll bring it up is just, as you can see here, the GLP-1 leads to increasing nausea, while GIP leads to decreasing nausea. So we can see that the side effects from tirzepatide tends to be lesser nausea and better GI tolerability when we're comparing to the other GLP-1 treatments. And we have another speaker that's going to go over this in more detail. And one other thing that I'll mention is that the genetic testing, we have been doing genetic testing over the last 5 years, and we have data collection now of about 500 patients. And what we have found for the patients that qualify for genetic testing, which are those that have a history of childhood obesity and or hyperphagia, where they have this insatiable hunger, and tends to be associated with mutations along the pathway, that 70% of those that we tested actually come back with a positive variant mutation, although many of those are variant of uncertain significance, but we do have over 70% of them with mutations. And we have worked with our psychology colleagues in looking how the genetic testing can impact overall outcomes. And what we have found is that opposite to many other conditions, due to the stigma and bias that we see on the treatment of patients with obesity, is that the patients are really upset when their genetic testing comes back as negative, because they're really holding on to this one thing that they thought if they had a positive that they had a reason for them to gain weight. And we see with the positive test results that they have some emotional relief, and they are more open to treatment, and then we see some of the frustration with the negative test results. Anyway, this is our clinic, and I'll pass it on to our next speaker, and we'll go on to asking the questions later.
Yeah.
Okay.
Thank you.
Thank you.
Should I put it?
Is this connected?